Thank you. Beautiful talk, Butch. So look, we've gone from something very common that we all face, and now I'm going to talk about something that's a little bit less common, and I hope that you can pick something of value out of it. Shoulder problems in tetraplegia, and this is part of a 10-minute part of a lecture that I gave at the International Tetra Hand Conference in Knoxville, and I just want to point that out because predominantly the people involved in the upper limb have been hand surgeons in the tetraplegia community, but now it's recognised there's a lot of shoulder pain, a lot of shoulder pathology, so I advocate that shoulder elbow surgeons also take an active role in managing these patients. Much of what I'm going to say is in a little review that has been published in Orthopedics and Trauma. So shoulder pain and tetraplegia, some main points. It is common, it is often significant, it may be multifactorial, and the associations, the risk factors for people who develop this include decreased range of motion and spasticity. When managing these patients, we recommend a multidisciplinary team approach, very important to work with your physician and the physiotherapist who are specialised in managing these patients. Conservative measures include activity modification, physical therapy injections. Surgery would advocate minimally invasive techniques where possible, and rehabilitation in a specialised facility. Some of the main things to really think about: the clinical examination and imaging techniques are similar to the evaluation of the shoulder in able-bodied patients. Shoulder protraction, adduction weakness, external rotation weakness, and an internal rotation deficit are common findings and may contribute to impingement. In chronic shoulder pain and tetraplegia, the overuse may contribute to AC arthrosis, subacromial impingement, glenohumeral arthrosis, so there can be multifactorial causes of pain. But always beware if there's progressive upper limb weakness to check for a syrinx with an MRI. Now, when looking at the non-operative options, consider wheelchair type and setup, the environment, transfer technique. These are all very valuable things to have in a collaborative clinic with your rehabilitation and physiotherapy team. Physiotherapy is often useful. Selective cortisone injections may be useful, and surgery, when undertaken, should ideally be done with the correct support for rehabilitation. So, I've said shoulder pain is very common. Prevalence 30 to 80%. There's some papers supporting that. How bad is it? 70% of patients in one study reported that it had a significant effect on their quality of life. The acute phase in tetraplegia is often associated with shoulder pain. 85% of patients in one study had shoulder pain after their acute admission, and this gradually decreased. There's an association with these patients getting shoulder pain of patients having a markedly decreased range of motion. So basically the risk factors for shoulder pain: increased age, spasticity, delay in starting rehabilitation, and decreased range of motion. So in your acute spinal injuries ward, it's important to really advocate for your patients to have early range of motion of their shoulder. So let's have a think about the shoulder in tetraplegia and what muscles are available, and we've done a little study looking at this. And adduction, extension, then external rotation tended to be the weakest movements. This has implications for muscle balance and impingement. We did some EMG studies, but absence of voluntary EMG was only seen in lat dorsi and only in patients with very high level injuries. So assessing the patient, we want to know about their spinal cord injury, any previous shoulder pathology, look at their wheelchair setup, their symptoms, the exacerbating factors, the impact on their activities of daily living, and their treatments to date. In the examination, once again, look at their wheelchair setup, posture, wasting, tenderness, spasm, and range of motion. And often these patients have myofascial trigger points around the trapezius and rhomboid. May have some AC joint tenderness as well, and as I say, a multifactorial cause of pain. And look at the movements and the weakness. As I've said, it's important to look at deltoid because that has great implications with the shoulder, but also with some of the more distal options for reconstruction of the upper limb, including deltoid triceps transfer for lack of active elbow extension, adduction and external rotation, and then some special tests. So in our experience, what are we seeing and how often are we doing something about it? If we look at this little audit that I did in our own spinal injuries unit, you'll see that of our patients, around half of them were tetraplegics, the others paraplegics, who we saw in our wheelchair shoulder clinic. Some of them had injections, fewer went on to have more high-tech investigations, and only a small amount had surgery. And certainly with the high-tech imaging, there's the challenge to match the symptoms with the pathology. So what's some of the experience? The French group from Montpellier have had a look at rotator cuff surgery in patients with spinal injury. And interestingly, looking at this, the neurological level, many of their patients were paraplegics. These are some of the things that they found difficult: transfers, propulsion, grasping, lying on the affected shoulder. And the surgical treatment of these patients, a number of rotator cuff repairs, some treatments directed at the AC joint. But once again, this points out that there can be multifactorial causes of pain and different things to be addressed. And the Montpellier group recommended a multidisciplinary approach. They talked about the concept of preventive or reconstructive surgery, and that really is, I think, beyond the scope of a discussion like this, and advised on appropriate preventative strategies. What's our experience in New Zealand? We have a spinal cord registry for spinal injuries, and looking at this, and I had a look at some of the data from that and from our national insurer of these patients, the ACC. And basically 8% of all serious injury claims, which are mainly spinal cord injury and some brain injury, register a rotator cuff injury claim at some stage. 2% go on to have surgery. But interestingly, although the majority of cases that we have acutely in spinal cord injury each year are tetraplegic and not paraplegic, the majority of patients who have shoulder symptoms and claims through our national insurers are paraplegic, not tetraplegic. That was a surprising finding. And let's look at the cost. In the right-hand column, you'll see the bottom line cost of treating the general public with a rotator cuff claim through our national insurer, $52,000. And look at the cost for the mean cost for a spinal cord injured patient, $450,000. This really has great implications on the finances, not only the lives of these patients, but the support that's required for them is considerable. And so if we sort of break down some of that, so much of that is on the support for independence in these patients in the serious injury, the spinal injury group, compared to the non-serious injury group. So in conclusion, these are very small group of patients. Many of them have shoulder pain. It's a huge thing for them to have a shoulder disability, but it's an even bigger thing sometimes for them to take on a surgical program and the loss of independence from that. And I would really recommend that some of you who are associated or have the opportunity to become associated with spinal cord injuries clinics take some leadership and work with predominantly hand surgeons to look at the upper limb and to do your best for these patients. So I'd just like to say thank you for that. And I started the talk saying that I presented this in Switzerland, but here at the journey, we're here in India, and it's been a very special time for me and my family with our hosts.